to be called doctor. But anyway, good evening to everybody that has joined us today. I'm very, very happy to be here, and I'm very excited to see, well, as much as I can, everybody that at least those who turn their cameras on. I'm currently research assistant professor from Department of Neurology here at the U. And I'm just going to share with you that for years and years, I pretty much was focused on science. And that's pretty much what I started, my training as a scientist. And I was very interested in pain in general. And I was very excited to learn about migraine. But I think more than about 10 years ago, I talked to a former boss of mine. I'm like, well, how can I actually really understand this huge phenomena that is called migraine if I'm only looking at mice and rats and nerve cells in the lab? I mean, I'm missing the whole human perspective. And I've always, been a therapist at heart. And so for more than about 10 years from now, I've wanted to actually explore the therapeutic modalities specifically that could be used for dealing with chronic pain and specifically with chronic migraine. So I got certified in many other modalities, and I had a private practice that I'm working specifically with people who are living with migraine disorders and tension type headaches, among other chronic pain conditions, but migraine is pretty much my focus. And it's like it's like I'm wearing two hats. Sometimes I'm like this scientist, and sometimes the therapist. And once these two, if they live in harmony, it's all good. But when they start arguing with one another, that might be a problem, and it definitely happens. So I'm hoping that in this talk today, I will actually give you both a little bit of the physiology and the science of migraine, some of the therapy, and kind of see the interlink between these two. And I'll be more than happy to answer questions. I think we have time at the end for Q&A, but I'm very comfortable if someone has a burning question they want to stop me in the middle, that's perfectly fine. Just unmute yourself, and I'll do my best to answer. I'm going to share my screen. Can everybody see my screen? Just kind of give me a thumbs up, or okay, you do. Great. All right. So the topic of what I wanted to talk today is about trauma, anxiety disorders, and migraine. Is there a connection? And I'm hoping that maybe at the end of this talk, I'll be able to convince you that there might be some pretty good evidence that these two have some link between them that kind of correlate between all of them. As I mentioned, I have two hats, so I'm just similarly, I'm going to divide this talk to two parts. In the first part, before we go into any therapy or therapeutic modalities, I think it would be very important to just talk about the physiology of what pain is, the definition, how does pain occur in the body, what is the problem with chronic pain, what are the types of chronic pain, specifically talking about osteoplastic pain. And then once we master as much as possible pain in general, I'm going to talk about migraine. What is migraine? What is the definition? What kind of types of migraine are there? What are the clinical manifestation? And a little bit of the pathophysiology. This is definitely not a lecture for med school, but I do think that getting a basic understanding of the mechanisms of pain and migraine are just important to understand about those disorders. And the second part, after we've talked about migraine and pain, we're going to cover what is actually the problem or problems that people that are living with migraine disorders are experiencing. We're going to talk about the stress migraine connection and mainly the emotional aspects of migraine, or how affect and all these other components that are considered to be emotional or affective are correlated with the experience of migraine. And we're talking about treatment. There is a lot of different kinds of treatment, but what I thought I'll do is to first talk about what some of us perceive to be some issues with current therapy. And I'm going to talk about two of the newest interventions that have been shown to be very efficacious for pain, and we're actually evaluating them currently now for migraine, which is pain reprocessing therapy and emotional awareness and expression therapy. And I'm going to mention some other useful interventions, such as the other modalities that I'm using. We're going to summarize, and at the end, I'm going to kind of give resources so that you, or if you want to give to your clients, if you know people that have migraines, then you can definitely use them. So pretty much what I wanted to say is that my goals for this talk is first to really explain the basic mechanisms of pain and migraine, the clinical manifestations, so looking at the physiology, then to understand the affective contributors to migraine and how they specifically affect the severity or the manifestation of the disorder, or pretty much that's under the umbrella of affect, and at the end to identify useful therapeutic interventions for migraine treatment and what exactly does that constitute. So I want to start with talking about what is pain. Now, the reason I want to start with pain, because whenever we hear people, if we're working with clients that have pain, or if we have pain, the main thing that we think is, oh, I don't want it, I just want it to go away. You know, this pain is horrible, it's horrendous, I want it out, just go away, which makes sense because it's an unpleasant sensation. So naturally, we don't want to have that. However, I thought that it would be important to maybe step back a little bit and start really thinking of what is pain actually, and why is it that we even have pain to begin with, so we can better understand how to relate to this experience. And so by the International Association for the Study of Pain, the definition of pain in general is an unpleasant sensory and emotional experience that is associated with actual or potential tissue damage or described in terms of such damage. Now, I wanted to make sure that you see that this phenomena has both a sensory or physiological and emotional experience. We have both. And so if that's the experience of pain, maybe it is important to treat both of them. However, pain is actually an evolutionary conserved phenomena, and the whole reason that we actually have pain is to protect us from real or potential tissue damage. So in essence, even though chronic pain or pain in general, we don't want it, it's horrendous, it's painful, we want it to go away. But when we sit and look at what pain is, actually, pain was created to help us, to protect us from something that is dangerous or that has potential danger to us or our survival. Now, the whole reason that pain is unpleasant is so that we can get our attention to it. If it would have been something nice or fun like a tickle, then it actually wouldn't do its job very well. But as I mentioned, every pain has both a physical component and an emotional component in very different proportions. Some we can say it's a little more physical, a little more emotional. It's very hard to put percentages, but it is a continuum that, in my opinion, most phenomena that are current, that are experienced as pain, has both the physical manifestation and emotional manifestation. In many chronic pain conditions, it seems as if that our system are caught up in this idea that we are in danger and we need protection. I'm going to say something about that shortly. Now, when we look at the mechanism of pain, before we go into the mechanism, first we need to understand that our whole biology, our whole bodies have been evolved and developed so that we will be able to respond to our environment. In order for us to respond accordingly to our environment, we need to have a system that detects things that happens outside. And when it detects those cues or stimuli from outside, the information goes from the outside through special system of nerve cells, and we are perceiving these cues outside so we can function according to them. This is why when we have receptors, for example, as shown here on the screen, when we have touch receptors, or those that are responsible for danger that I'm going to talk about in a minute. All of those information are being collected, interpreted from the periphery. The information goes from the periphery through the spinal cord and to the brain, where this information is being processed so we can do something with it. And similar to that, all of our other sense organs, such as vision or hearing, these are all the same principles of specialized systems that are able to collect these stimuli, either wavelength or sound waves and so forth, and get the information to our brain so we can process that and do something with it. So with that in mind, we can actually understand that when we talk about nociception signaling, or the identification of danger signals leading to a sensation of pain, it all starts in the periphery, in our hands, in our feet, somewhere outside of our brain, the peripheral system. These signals are interpreted by specialized peripheral receptors and nerve cells that are called nociceptors. This information goes to the spinal cord in the form of electrical impulses. That's the message, that's the language that the nerve cells, that the nervous system is using. From the spine, these danger signals are going through the brain, and those danger signals are being evaluated, where a logical story is being processed. What is the signal? Did I experience that before? What does that mean? Am I in danger? And so forth and so on. In the brain, we have many different areas that a lot of people are calling them different names, either pain centers, pain metrics, ignition nodes, it doesn't matter. But the fact is that this information that is going to the brain is processed simultaneously in many different areas, and eventually the experience of pain is being generated if the system identifies the sensory experience as dangerous. What I want to emphasize is that when I'm mentioning at the beginning that the pain starts with a danger signal, it's not a pain signal. It's a danger signal, like inflammation, like a cut, like a bruising, or like a pinch from a needle, for example. Those signals are danger signals. Whether they're painful or not, that happens in the brain, not in the periphery. So whenever we have pain, pain resides in the brain, not in the peripheral system. However, what I wanted all of you to take from that is that if our brain determines that we are in danger, it will produce a pain signal. If the pain does not determine that we're in danger, it will not produce a pain signal. Now, before I move to the next slide is going to have an image that might be a little disturbing to some of you. So I just want to give a kind of like a heads up that if it's a little too much, you can, shift your view from the screen. And what I want to show in here, this was an actual case of a builder about age 29. It was in a construction site. And there was an accident that he jumped in the construction site, and he actually jumped down on a 15-centimeter nail, and the nail pretty much pierced his boot. I see some people kind of squinting their eyes. That's actually interesting. We're going to talk about that. So what happened is that this person was so much in agony that he went to the ER. They needed to sedate him completely. He was in so much pain. And guess what happened? After they sedated him, they took the nail out and they took the boot out. Actually, the nail didn't even touch his skin. The nail got in between his toes. Yet the person was in so much pain that he needed to be sedated. And I'm wondering, that story, what does it tell us? Maybe it tells us that our brain and our perception or interpretation of danger can actually cause us to be in pain, even though, like, when we look at the evidence, there was not even damage or any danger to the tissues. So that's an interesting concept that let us think about what is the role of the brain when we talk about pain in general and chronic pain. And beside that, there's other important facts about pain, such as the fact that pain is dependent on context. For example, if I were to have like a finger injury, the same finger injury, if it would have been for someone who plays the violin, for example, versus someone who does not, or like a construction worker, the level of pain would be described as different, because the meaning of what is the meaning of if I'm injuring my finger for a violinist that has implication on his career might have an effect on how much they are rating their pain. Another example, let's assume that will never happen, but let's assume I meet you down the street and I'm going to bump into you, and I'm going to say, oh, I'm sorry, excuse me, I didn't mean to bump into you, please forgive me. Versus, let's say I bump into you and I'm going to say, serves you right, you deserve it, serve you right. Of course, it will never happen. But in both cases, it might be that the report of pain in the second incident might be higher than in the first. We also are aware of the nocebo effect of pain can be amplified if it's preceded by anticipatory or increased pain. So if I'm going to connect you to something and say, okay, take a deep breath, this is going to hurt, this will hurt. If just by anticipating the pain, you might rate the pain higher than it actually is. We're also aware of our virtual body, like phantom pain, that pain can exist without the body part present. We're all are aware of phantom limb pain, that people are actually experiencing pain in a limb, even though it was amputated. And also, tissue damage is not enough to explain the different levels of pain experience. There's a lot of experiences, a lot of experiments that have been done that actually recorded different activities of nociceptors in peripheral tissue that showed activity that was not enough to elicit a pain response. So even though we have the message coming from the periphery, the person still did not interpret or report a pain sensation. Also, we know that pain is experienced differently depending on age, depending on gender, depending on culture. A lot of time, and again, maybe I don't mean for it to be a sexist remarks, but a lot of times, guys, they want to be tough. And so if I'm doing something painful to them, they're like, oh, no, it didn't hurt. It didn't hurt at all, even though inside there might be shivering. So all of those abilities to attribute meaning and perception to pain are influencing the level of pain. And of course, there are much more to say about that. But all of that is actually to say that when we talk about pain in general, pain exists in the brain, one, and second, pain is malleable to a lot of different perception or attribution that is given to the story of pain. However, when we talk about pain, it's not just acute pain. The story becomes much more complicated when we talk about chronic pain. In chronic pain, the longer that we have the pain signal, the more sensitive the danger system becomes in the spinal cord. This is a process called central sensitization. And usually when people experience the sensitization, it's like the system becomes very hyperexcitable. So even signals that are not painful, such as brushing the head or putting a shirt on, or even taking a feather and lightly stroking the skin, that could be perceived as painful. It's not imaginary. It is because there are changes in the system. That process is called allodynia. This increased sensitivity in the spinal cord, and of course, later on in the brain, transmits the information that is no longer accurate about the danger. So the danger is gone. The person is no longer in danger. It might be that the wound or the injury has already healed, but the system keeps going on as if the danger still exists. And what happens is when the brain needs to adjust itself to the flood of information, it becomes more sensitive. And if you want to use an analogy, it's like when we have a symphony that normally can produce all sorts of different tunes and beautiful music. And with chronic pain, it's like the symphony is just playing the pain tune. And it's like all the signals now, it's like they're hijacked. It's like the brain was hijacked mainly by the pain signals. So everything else that might not be dangerous is interpreted as dangerous. In that kind of condition, whenever there are other cues that signal danger, such as negative thoughts, such as stressors, such as negative emotions, those can amplify the experience of pain, which is why we're going to talk about this correlation between emotions, negative effect, and so forth, and chronic pain. So this is kind of just a general idea of what is happening physiologically in your body. And again, this is very broad and inaccurate, but just to give you an idea of what happens in the body in a lot of those chronic pain conditions. I also want to say that there are different kinds of chronic primary pain. One is called nociceptive pain. Nociceptive pain is caused by an ongoing inflammation or damage to a tissue. Whenever we have a cut or a bruise, the tissue is injured, it releases some chemical mediators. We're not going to talk about them right now. That's beyond the scope of this lecture, but those are causing sensitization of those nociceptors transmitting the danger signal response. Contrast to that, there is neuropathic pain. Neuropathic pain is pain that is caused by either a damage or a lesion, or that is called also by a disease to the somatosensory system. In the neuropathic pain, unlike the nociceptive pain, we have an actual damage to those nociceptors. And when I hear a lot of people say, well, wait a minute, if you have a damage to the nerve or the nerve cell, shouldn't it just kind of eliminate the pain? You know, like when you take a telephone cord and just cut it and you don't have the line. That is a nice analogy. However, biology is a little more complicated. And when we have damage to a nerve cell, there are specific processes that occur that lets this nerve cell to start being active, what we call ectopically, meaning the nerve is start to transmit a signal very, very strongly and constantly, which enables neuropathic pain to be chronic pain. The third type of pain that is relatively new, that has been added to the International Association for the Study of Pain, I think about 2016, and that's relevant for our talk today, is nociplastic pain. With nociplastic pain, people are actually experiencing pain, and the pain is originating from some change or alteration of the nociception response. There is no evidence of trauma, there is no evidence of inflammation, there is no evidence of injury to those nociceptors. However, there is physiological evidence that something in the pain processing system has changed, allowing the person to feel this increased pain. So this is a new definition that allows us to assume that something has happened in those pain, in this pain system that is not related to trauma or injury. How do we know that someone has nociplastic pain? And I just want to emphasize, this is not a diagnostic manual. This is not to help you diagnose it, but it is to give us an idea of how to start thinking of whether someone has nociplastic pain or some other form of pain. So pain that originated in times of stress with no signs of any injury or trauma when I'm saying physical trauma, is one criteria. Pain without an injury. When the systems are inconsistent, like pain, like person says, yeah, I have a pain in my leg, and then it goes down to my knee, or now I'm experiencing that in my soul, now it's back up in my leg, and so forth and so on. When you have a large number of symptoms simultaneously, yeah, I have a pain in my leg, in my knee, in my shoulder, in my head, I have migraine, now I want to emphasize, sometimes we have multiple symptoms. However, sometimes large number of symptoms that do not seem to have correlation can indicate nociplastic pain. Symptoms that just spread or move. Yeah, I had a pain that was just really, really localized in my knee, and all of a sudden it's completely in my leg, and now it's back in my knee again, and so forth and so on. Symptoms that are triggered by stress. Yes, whenever I get stressed, I experienced those symptoms. Symmetrical symptoms, like when I have exact same pain in my left knee and in my right knee, in my left hand, in my right hand, so forth and so on. Childhood trauma also can indicate that some of the pain might be nociplastic, as we're going to talk about. Lack of physical diagnosis, when all those people went to every possible intervention and diagnosis and MRIs and scans, and no one can find what is wrong. No one can find actual physiological or anatomical abnormality. When there's general symptoms according to the pain that accompany the pain, such as general fatigue, such as memory issues, emotional issues, such as depression and so forth. Environmental sensitivity, when people are experiencing light sensitivity or sound sensitivity or smell sensitivity, which is very found in migraine. So these are just examples of when people experience any of those, we might want to think, that sounds like something that might be categorized as nociplastic pain, even though we're still not allowed to diagnose it at this point. So now that we're experts in pain, I want to move on to migraines. And I want to start by saying that we hear a lot in the common jargon, oh, he gives me a migraine, or she gives me a migraine. My mother-in-law, she can't stop talking, she's giving me a migraine. But the fact is that not every headache is actually a migraine. So if we want to have a very simple tool, if someone tells us, I think I have a headache, no, maybe it's a migraine, I'm not sure, a very simple tool that you can use to ID the headache is answering 3 of those questions. 1, are you nauseated or sick to your stomach when you have a headache? 2, has a headache limited your activity for a day or more in the last 3 months? And 3, does light bother you when you have a headache? People who answer a yes to 2 out of the 3 of these above questions have an 80% probability that it's a migraine. If they answered 3 yeses, it's more than 93% that it's a migraine. So this is a very, very simple tool to kind of allow you to assume whether someone is talking about a migraine, a headache, and how to differentiate between the two. We're not going to go over the classification. I just want to show you that there's very, very different kinds of migraine. We're not going to cover them. But usually when we talk about migraine, the main classification that everybody talks about is migraine with aura and migraine without aura. So let's just talk just briefly about what are the criteria for migraine. So first of all, migraine is considered a chronic episodic disorder that is characterized by episodic attacks of headache and associated symptoms. It is considered a neurovascular disorder, meaning that you have a neural component and a vascular component in it, not just the theory of the vascular component that was neglected. It is estimated to affect between 12 to 18% of the population, and it's worth to say that women are 3 times more prone to migraine than men, especially after puberty and before menopause, which lead us to think that estrogen, sex hormones do play a role in migraine, allowing for this a 3-to-1 ratio. The diagnostic criteria for migraine without aura is that people need to have at least 5 attacks. Each attack is between 4 hours to sometimes 72 hours. Yes, sometimes people experience 3 days of migraine. And the headache needs to have at least 2 of the following: unilateral location, so that the headache is always in the left, the right, and it could move, but it's usually in either place, not the whole head. Pulsating quality, meaning it's not tightening, it's like this vibrating or pulsating quality of the pain. It is exacerbated by moderate to severe it can be aggravated by physical activity. So that's why people really withdraw from any physical activity when they have a migraine, and the intensity is moderate and can be definitely very severe. During a headache, at least one of the following need to occur: nausea, vomiting, or both, or sound sensitivity, which is called phonophobia, light sensitivity, that is called photophobia, and a lot of time smell or scent sensitivity, that's called osmophobia. When I'm kind of looking at like the typical person who suffers from migraine, especially in a migraine attack, you can see them with a very dark sunglasses. It could be 10 p.m. at night. They're still going to be with sunglasses in a completely isolated room, no light, no sound, curled up with a blanket on themselves. They're going to do everything they can to make sure they're not being exposed to any noises or stimuli from the outside. So it's like their whole system is sensitized. It's like taking like a radio, taking the volume and cranking the knob all the way up. This is kind of the analogies I'm using to describe people that are living with migraine. When we talk about the aura, sometimes, not every case, but a lot of people are seeing changes in sensory perception that could last either 5 minutes up to 60 minutes. The typical auras usually are visual, when people are seeing these disturbances in the visual fields, but they're not the only type of aura that exists. There are other forms of aura that are usually reversible. Beside the visual aura, there's actually sensory or speech aura. So sometimes people are feeling this tingling, like ant crawling under the skin, and that kind of gives them a sense of, oh, I have a migraine coming. Speech or language disturbances. It's like all of a sudden they can't put sentences right. They can't recall words. Their grammar is completely off. Sometimes there's motor disturbances. There are, of course, other brainstem and retinal disturbances, but the most common is the visual. What is usually occurring is that the aura, which can last from 5 to 6 minutes, usually precedes the headache phase. And when we talk about the visual aura, it usually looks exactly like that. It's like there is this it's called scintillating scotomas, or these flickering lights. And then after those flickering lights, there is a blind spot to indicate that physiologically we have positive symptoms and negative symptoms. This is another example of like auras, and people report it in all sorts of ways. We have these zigzags or kind of flickering lights. There's all sorts of ways that people describe their auras. When we talk about the clinical manifestation of migraine, usually people have premonitory symptoms. They could occur either hours or days before a migraine attack. They usually can be psychological. People feel irritability or depression or moving constantly. Some people can feel drowsiness. There are sometimes neurological symptoms such as difficulty concentrating, light sensitivity and sound sensitivity that are not during the migraine attack. And sometimes they have systemic changes like stiffness, like coldness, like all of a sudden there's like really desire to consume all sorts of foods, or being very, very thirsty all the time, or urinating a lot, and so forth and so on. After the premonitory symptoms, usually premonitory symptoms that doesn't occur in all cases are indicative for a lot of people to say, oh, if I'm experiencing that, I better watch out, there's a migraine coming. So usually after premonitory symptoms comes the aura or not, depends on the case. The migraine pain, which could last from 4 to 72 hours, and then there is a resolution or postdrome. And what is important with the resolution or postdrome phase is that even though the pain has dissipated, it still affects the person. We hear a lot of people that say, oh, you know, I have a migraine yesterday, I'm completely stupid today. They really mean it, that they cannot concentrate, they can't do anything, even though they don't currently have migraine. So this is why we call it the postdrome phase. Some of the migraine triggers that are physiological migraine triggers is food, like diet, if I'm hungry, or if I have some food additives or alcohol, caffeine or caffeine withdrawal, all those can be a migraine trigger. And the numbers of food that could cause triggers is enormous. I constantly learn from more and more clients that they have another food that I never heard that causes their migraine. So I'm always learning a lot about that. Hormonal is very, very important because, as we mentioned, women are 3 times more prone to migraine than men. Times of hormonal changes, such as menstruation, menopause, pregnancy, can very much affect migraine in both ways. Some people have what we call menstrual migraine. There is migraine associated with the time of the month. These are really debilitating. Some people during pregnancy, their migraine go up. In other cases, it's actually the opposite. I know someone that said, I wish I could be pregnant for the rest of my life because I didn't have any migraines during that time. Menopause also, a lot of people, some women I know during menopause, their migraine stopped. Sometimes the migraine actually started, so they needed to go on oral contraceptives. Environmental cues like visual stimuli, odors, changes in air pressure, all of those can be migraine triggers. And usually people with migraine would refrain from places that there's too much flickering lights or too much noise or, very, very specific scents and so forth and so on. And also importantly, a lot of people report that stress, whether traumas we're going to talk about, stress at work or stress at home, anxiety, are the ones that are going to trigger the migraines. However, I want to say that it's very important to identify triggers, but it's also extremely tricky because a lot of those triggers are not that well known. In a lot of cases, it can be easy, like some food that you just avoid. In other cases, I know people that just spend years and they still haven't figured out what triggered their migraines. Just last on the pathophysiology, just so we have a basic understanding of what it is that happens in the brain that is responsible for migraine. The current theory about migraine is that there is some trigger that starts a cascade of events that we're not exactly sure why it actually starts that, but the initial trigger for migraine is called CSD, or cortical spreading depression. This is the underlying pathophysiological mechanism for the migraine aura. This change in the brain and in the nerve cells and accessory cells actually cause activation of those nociceptors belonging to the 5th cranial nerve, or the trigeminal nerve, shown here in pink. This activity is actually being transmitted to the brainstem to an area called TNC, where the signal is going through the thalamus and from the thalamus to the brain, where the signal is being transmitted and interpreted as painful. That's very, very general of what causes migraine and how does migraine occur. There are many other mechanisms and there are many other theories. It's a little outside the scope of this lecture, but this is the predominant theory up to this point. What is also important to know that we have sheets enveloping our brain. Those sheets, the external one, which is called the dura or dura matter, is filled with those nociceptors, those specific cells that are responsible to identify those danger signals, thereby leading to migraine pain. So we're experts in pain. Now we're experts in migraine. So now, what are actually the current problem that people with migraine are facing? And that's pretty much the second part of my talk. And what I wanted to say is that a lot of people with the migraine disorders currently are not responding to the drugs that are around. I know we have new drugs lately, the CGRP antagonists and so forth and so on. Even though they've been helpful to some there are some people who are still not responding to medications. When we have attack frequency that is inconsistent and someone doesn't know when their next migraine is going to come, that pretty much doesn't help having a good sense of hopelessness, and people a lot of time feel defeated. It's like, I don't know when the next attack is going to come, and that causes them to be very angry, very depressed, very anxious. A lot of people with migraine, because of that, are on disability. Because they're on disability, they can't go anywhere. They can't be in social events. They can't go to the movies. They lack a social network, and they feel isolated. When people feel isolated, usually that doesn't really help them feel good about themselves or life in general, which can be considered a stressor. And another very important thing that I actually wasn't aware until we started the group sessions that we're doing is that migraine is considered a very stigmatized disease. And a lot of the migraine sufferers really feel misunderstood and lonely. One of the main things that, the main feedback that we got from people is that when they were in group with other like-minded people, just the fact that they were able to be understood, that everybody understood what they're going through, that we were like-minded people, that by itself was very therapeutic to them, because a lot of them are very, very feel alone, and they feel as if no one understands what is it that they're going through. So these are some of the problems that are occurring. And that leads me to think about what is the correlation between all of those stressors and migraine. We do know, according to the literature, that migraine is associated with other conditions such as general anxiety disorder, such as depression, just to name a few. And when we think about it, it might not be coincidental that if I'm experiencing these, random headaches that are completely debilitating, that I can be in bed for 3 days, it might make sense that I'm going to be anxious of when is that going to be the next time. However, it also is known that this correlation is bidirectional. So yes, migraine can affect anxiety, but increase in anxiety can also affect migraine. Also, people just with anxiety disorders seem to be much more preoccupied with their bodies, and a lot of time are experiencing pain symptoms. Migraine is one of them. The prevalence of major depressive disorder has been shown to be 2 to 3 times higher in people living with migraines compared to the general population. And also there's a 10-fold likelihood of people living with migraine to experience either anxiety, panic attacks, or both compared to the general population. And we also know, based on literature and based on experience, that when people have both these comorbid psychiatric disorders and migraine, usually that is very much associated with much poorer health-related outcomes. A lot of those people are really disabled. They have reduced quality of life. They are very much on disability. They can't go anywhere. A lot of them have suicidal ideation. And a lot of times, in order to do something about it, they're overusing medications. Medication overuse can sometimes just perpetuate the problem, so the cycle keeps going on and on. So all of that can cause an increase in use of mental health and doctors, nurses, and so forth and so on. But when we think about this association between those anxiety or stress disorders and migraine, we tend to think, well, what may be the common denominator that might explain the existence of both in the same time? And one of them was postulated to be stress. And when I'm talking about stress, I'm referring to the fact that usually when we experience acute stress, we go into a fight or flight mode. Our physiology changes, like an increase in heartbeat, increase in breathing, sweating, and so forth, so on. Our system need to adapt to the environment. So we are engaged in a stress response, and when the stress is gone, the response is dampened. However, when stress becomes chronic, usually what happens is that the physiological processes that are responsible for all these physiological adaptation, they become fatigued. That process is also termed allostatic load. And when these processes are fatigued, they have been shown to contribute to changes in pain processing and increase in central sensitivity. It's like the whole system seemed to be much more hyperexcitable. When these things happen, then we have changes, specifically migraine, with an increase in duration, increase in frequency, increase in severity of symptoms, and medications a lot of time can become ineffective in those cases. But also when we have chronic stress and all those changes in the system, these physiological changes can also precipitate other psychiatric disorders such as anxiety, such as depression, and if severe, post-traumatic stress disorders. So there is a notion that there is a lot of physiological correlates between those affective disorders such as anxiety, depression, PTSD, and the occurrence of migraine. So it's not coincidental that those occur simultaneously. And one of the reasons that they could be occur simultaneously is because of chronic stress. Moreover, emotional chronic stress has been reported as a migraine trigger by 59% of the migraineurs in a clinical-based population study. But that's not the only one. Beside the fact that stress has been shown to be a precipitating factor for migraine, was also shown that traumatic experiences such as child abuse or child neglect, sexual, physical, or emotional trauma has been linked with occurrence in general with chronic pain, but also specifically with migraine. In population study, it was shown that people living with migraine actually have higher incidence of abuse or neglect compared to the general population. And that correlation was irrespective of other anxiety disorder. A higher ACE score was also associated with the occurrence of both migraine in adulthood and with chronification of migraine. So we do know up to this point that migraine is linked with those other stress or anxiety disorders. Chronic stress can perpetuate migraine, can initiate or exacerbate migraine, and it might not be just coincidental that a lot of people experiencing migraine also has a higher incidence of past trauma or past abuse. Regardless of that, several therapeutic modalities that have shown to help people with stress management did show that we're able to contribute to improving of migraine symptoms. However, I'm going to say something about that because there are also a lot of problems with some of those therapeutic modalities. Mindfulness-based approach in some cases were shown to help migraines, but there are studies that mindfulness actually was not shown to be efficacious for migraine. But so when we talk about the stress and migraine connection, some of the stressors that can exacerbate migraine can be, as I mentioned, childhood adversity, workplace issues such as bullying, discrimination, harassment. A lot of people that feel misunderstood because they have migraines and bullied by their peers because they took time off because they have migraine, but actually they really weren't able to help to work. Healthcare issues when doctors, nurses show skepticism, kind of, well, you came back to me pretty much every week now, so you wanted to tell me that no medication has been helpful? I don't know, are you sure you're not faking it? I hear that a lot with my clients, and there's nothing that could demoralize them more than that when even doctors don't believe in them. A lot of time there's a misdiagnosis, or a lot of doctors actually contribute migraine to just a mental disorder. It's like, well, you know what? It doesn't make sense. This whole migraine, this whole headache really doesn't make sense. I think you're just, there's something wrong with you. You need to go to a psychiatrist or something. Maybe they could help you. Feeling alienated by healthcare system can definitely be a stressor for a lot of those people with living with migraine disorders, but also people that are feeling misunderstood, especially by their friends, their family, their spouse, significant other. As I mentioned, migraine is a stigmatized disease. A lot of people that are suffering from migraines, they look completely normal. There's nothing that actually is physically, or when you look at them, there's nothing that actually is wrong, but they do still experience the pain. With that in mind, a lot of my clients report that some, people are just telling them, well, what do you mean you have a migraine? Just step up to the plate, go have a glass of water, go take a breath of fresh air, and get on with your work. And they can't. This lack of affection, lack of support, the stigma is really causing a lot of those people living with migraine to having increased stress. Self-blame, inability to do regular activities, struggle with self-esteem, and all of those negative emotions, such as, why do I have migraine? Why does no one believe me? Why is it life is so cruel to me? Insurance is causing me issues. All of those are part of the life of people who are living with a migraine disorder. Now, when we talk about stress, I just want to also emphasize that it's not just kind of imaginary stress. It's actually, there's physiological basis for those processes that occur inside our cells. When we talk about the pain signal that goes to the brain, pain and migraine signal is going through different brain areas. Some areas are specifically physical, allowing us to know what is the level of pain, where is the pain located, and so forth, so on. But some of it is actually emotional. Areas like the limbic system actually are involved with pain anticipation, anxiety, somatic preoccupation, and so forth and so on. So when people are responding stress or anxiety or catastrophizing, it's not just imaginary, they're actual anatomical, physiological basis to those experiences. Some interventions that are important enough to help people experience those affective conditions have been shown to work on those areas that were elevated in people suffering from migraine or chronic pain. So I just want to give some examples from my experience of some triggers that are considered emotional triggers. Now, the reason that I wrote possible undetermined triggers is because the jury is still out on that. I just want to give some examples to say that those might be able to contribute to migraine, because in a lot of cases when they were worked, we were able to help people with migraine, but in a lot of cases, we just don't know. So an example is a client that I had that came to me with a chronic migraine almost daily. She suffered from migraine. There was pretty much no day that she didn't have a migraine. And when I worked with her, it seemed as if past traumatic experience that has not been addressed or resolved was being the one that perpetuated probably the migraine, because when we were able to resolve or desensitize that, she was going down from every day to 3 times a month. Her migraines were not gone, but they were very much improved. Another example is a client that had a mixture of migraines and daily headache. And when I talked to her, it was very clear that she was the one of the people that took the whole world on their shoulders. She did everything to everyone, worked tons of hours and overworked, very, very stressed. I was able to help her to a degree. She still has migraines, but it did seem as if her inability to take time off and actually take a little load off her shoulders seemed as if it was creating this internal stressors, thereby leading to her migraines. Another example that I have is someone that came to me with migraine that started 3 years ago. And what was interesting is that when I talked to her, I asked her, so when was the last time you had a migraine attack? And she said, oh, I had it last week. So I asked, well, what exactly happened? What triggered that? It was like, no, nothing. There's nothing that triggered that. I was just talking on the phone with my brother, and after that, I got a migraine. And then I started questioning a little more. What exactly happened in that conversation? And she was like, well, I don't understand why you're asking me those questions. I mean, it was stressful, but nothing much. And then she said, I felt as if I don't have a voice as usually that happens with my brother. So I asked, okay, did you ever felt that previously, like when you were a child? And when I asked that question, she started to cry. And it seemed as if this experience was very much accompanied her a lot of time in her childhood, when this feeling of unsafety, the feeling that she doesn't have a voice to speak up, was a huge stressor for her. When we're able to work with that, she actually got better. But I do want to say that because she's also went through other forms of intervention, I can't say that that was actually the thing that created the resolution. But in her mind's eye, the fact that each and every time when she felt unheard, she felt a migraine come up, which led me to think, that is kind of interesting how our emotions work and when we feel unsafe. Another example are two clients that came that are they are LDS. Both of them experienced relationship issues that were very much, they did some things in their marriages that contrasted their religious beliefs. Those inner conflicts from what came in therapy seemed as if were a big stressor for both of them. I was able to help only one, the other just left, but it did seem as if resolving or helping clear more of that conflict definitely help reduce the migraine, but not eliminate it. Another client that did not have migraines, but he did come with chronic back pain. And again, all of those clients came after they've done everything in the book in terms of medicine. Nothing was helpful, nothing was working, no medication, no treatment, nothing was able to get them some relief. So when I talked to this guy that had recurrent back pain, and when I identified what was going on, it seemed as if there was some anger, resentment toward some issue that happened with his marriage. And once we were able to desensitize that, he reported, well, I definitely feel a reduction. The pain is not eliminated, but the pain is reduced. So all of those cases kind of let me speculate or assume that maybe those triggers, as we talked about emotional stressors, maybe working on them can have an effect on migraine, as in some cases it did work, in other cases it may not. This is why I said that the jury is still out on that. Another thing that I want to say, and this is a comment that came from my course, which I thought was interesting to put it in here, that one of the participants said, I gave them an exercise of mindfulness and some relaxation exercise that it was not related to pain whatsoever, but she said, during the exercise, I experienced a sense of loss, grief, and aloneness, as if pain can become something of a friend in a dysfunctional way. And then she asked, well, I wonder if this is something you'll be addressing, and so forth and so on. Which I don't know who that participant is, because it was a large group and these questionnaires are anonymous. But I think it was very interesting, as she mentioned, that when she experienced the sense of loss, grief, and aloneness, pain can become a friend in a dysfunctional way. So I have to wonder, if that's the case, if we address this loss, grief, and aloneness, would that help their migraine? And again, this is a question that is open, that I'm raising in this, in this talk today, because I'm constantly wondering how much of those emotional stressors are actually connected to the occurrence of migraine. In a lot of cases, from my experience, resolving them can produce changes in the experience of migraine. So just to recapitulate and just to kind of summarize what we've mentioned, when we talk about the possible emotional triggers for migraine, when we talk about unresourceful emotions such as anger, sadness, fear, hurt, guilt, and so forth and so on. When people engage in negative self-talk, this migraine was never going away, no one believes me, life is hopeless, I'm a loser, so forth and so on. Unresolved grief over something that happened or someone that died, relationship issues and relationship conflicts, people that ruminate and so they also have trouble sleeping, people that hold to grievances stories and they don't let go of things that happen to them, emotional conflicts in past or in present, and childhood trauma. When I'm looking at all of those, I have to think about the occurrence of internal stressors. And when we have those internal stressors, those might contribute to a sense of danger. We already know that pain is a danger signal. So is it possible that existing of those internal stressor can perpetuate a sense of danger, which causes an increase in stressors, and the cycle goes on and on and on. So the last part, and I'll conclude with that, is what can we actually do about migraine, knowing everything that we know about migraine and pain and the emotional component of migraine? What is there to do about migraine? So some of the, before I get into the techniques that I wanted to talk about, there are some issues with the current approaches to pain. And I will just say that currently now there's a lot of debate of which is the optimal approach for treatment of chronic pain and chronic migraine. There are the current approaches which are considered the golden standard, such as CBT, mindfulness, acceptance-committed therapy. All of them are good and showed some efficacy. However, a recent Cochrane review indicated that those interventions were good on the short run. In the long term, a lot of them were actually not that efficacious. Chronic pain is also a heterogeneous disorder, meaning that not every pain is identical. Some pain has central components, some pain is neuropathic, some pain is nociplastic. It doesn't mean that the treatment need to be identical to all of them. When we have centralization of pain, such as in nociplastic pain, the intervention need to be different versus those pain that actually have a physical component to it. A lot of time there's a weak link between abnormalities of imaging and pain symptom. That is very prevalent with back pain, that a lot of time people are getting a diagnosis like you have a bulging disc or you have spondylosis and so forth and so on. Well, actually, recent evidence have indicated that there's a lot of people with the same disorders that do not experience pain. So in a lot of time, when we're giving a diagnosis, it might be helpful for the individual. Oh, yeah, I have a diagnosis and I know what my problem is. However, in a lot of times, these diagnoses might be misleading because there's a lot of evidence that even though people experience this bulging disc, they're not necessarily have pain. So in a lot of those cases, which that's the reason for nociplastic pain, there's treatment that can actually help versus making sure that I have the diagnosis and so there's nothing to do with that and I don't need to treat it. It's just the way it is. The notion that the brain does not only modulate pain, but can generate pain, such as hypnotically induced pain, nocebo effect, and so forth and so on. The fact that adverse life experiences and inner conflicts can very much contribute to chronic pain, as I mentioned. There's a lot of approaches that are focused on coping mechanism, and they do not address all of those emotional conflicts and trauma issues that occur. And so pretty much there's a lot of ongoing debate of which one is the best approach for treatment of pain or not. So I just want to just 5 more minutes and then I'll conclude. Two of the more recent approaches for pain, one of them is pain reprocessing therapy, which this sits on the notion that when we're faced with chronic pain, there is a pain-fear cycle that perpetuate one another. So when I have a pain attack, or if I even have an indication of a pain attack, I'm going to really, really be anxious. If I'm going to be anxious, this increase the sense of danger, leading to increased pain and so forth and so on. I'm actually working with someone in my biofeedback course, and she just mentioned the other day that she was sitting at her house, everything was fine, and she felt this stabbing sensation in her forehead. And she just raged into a panic attack, and her heart rate was racing, and she couldn't calm herself down. She went to the hospital, and pretty much she was so anxious, after several hours, her heart rate went down. After that, she got a migraine. And I have to ask myself, would it be possible if you first experience the sensation, if you would be able to calm yourself down, would that have prevented your migraine? I don't have an answer to that, but it seems as if her initial perpetuation of her condition might have contributed to her occurrence of migraine. So when we're working on pain processing therapy, this therapy intends to pretty much break the pain fear cycle by training the individual to actually sit with their pain, but sit with the pain with a sense of lens of safety. If the pain is too severe, this is not the time for pain reprocessing therapy. But because there's a lot of wanting to distance and push pain away, what pain reprocessing therapy does is actually enable the person to sit with a sensation and experience painful sensation through a lens of safety. This is done by combination of mindfulness approaches, safety reappraisal, where we keep repeating the fact that, hey, this is just the mind overreacting. It's not necessarily needs to flare up. I am safe. I am in a safe place. I can calm myself down and have positive affect in that. There's a study that used pain reprocessing therapy in back pain that showed tremendous results of more than 90% of individuals reduced and eliminated their back pain. So pain reprocessing therapy is one option that is relatively new that I find to be useful. Another one is emotional awareness and expression therapy, or EAT, which this is a form of psychotherapy that emphasizes the resolution of unresolved trauma and psychological emotional conflicts. It's been researched several times with many different kinds of pain, such as urogenital pain, fibromyalgia, musculoskeletal pain, and so forth and so on. We're currently testing EAT for migraine. Since this approach is very similar to what I've already done in clinic, it made sense to actually go ahead and do a thorough research on it. I don't know at this point if it's going to be effective for migraine. I will have an answer hopefully in a couple of years. We're actually doing the project right now. However, the idea behind EAT is that emotional baggage, as we mentioned, contributes to the danger signal, thereby promoting chronic pain. So what we do in EAT is actually help people better express their unresolved emotion or suppressed emotion, thereby leading them to have a resolution. And in those studies, we see that people are actually not just coping with their pain is actually decreased. The principles of EAT is that, as I mentioned, pain generates and amplifies pain. It's been shaped by life experiences and all of those stressful experiences that happen to people in their life, leading to those unresolved inner conflicts and emotions that we want to have them experience in real time and get to a resolution. Just to show a schema about that is that when people have emotions, instead of avoiding them or suppressing them or bottling them up, which can cause internal stressor leading to pain, with EAT, we help them further experience emotion that lead to reduction in pain and normalization of brain activity. Again, we're right now testing it for migraine this coming year. So hopefully, from what I'm assuming, it will be helpful for migraine, but I'll need to wait for that. These are the only interventions that are helpful. Other interventions that I found to be helpful for migraine are biofeedback, when we're connecting people to in real time to cues, and they're able to learn about their physiology and learn about their physiological system as they're being done. Usually the point of biofeedback is because a lot of people with migraine are afraid of their body and feel the sense of lack of control, when they start to realize that all of those autonomic phenomena, such as skin temperature, such as breathing, heart rate variability, and so forth and so on, can actually be better managed, it gives them a lot of sense of self-efficacy. Biofeedback has been shown to be efficacious for migraine. It has a level 4 evidence-based, and for tension type headache, it's actually effective and specific, and therefore has a level 5. So biofeedback, which is one of the techniques that I'm using, I find to be helpful for people with migraine. Hypnotherapy, it's a huge umbrella for a lot of techniques. With hypnotherapy, as far as I'm concerned, hypnotherapy is just a learned process of adopting a specific mindset that can be used for many things, like pain reduction, building resources, cognitive restructuring, stress inoculation, and so forth and so on. I found that hypnotherapy, and there's also a lot of studies to indicate that hypnotherapy can be helpful for migraine. Trauma-focused psychotherapy, such as EMDR and other trauma-focused psychotherapy, were researched and shown to be efficacious for a lot of pain conditions, migraine included. Pain exposure therapies, where people are learning how to actually not avoid movements that are causing pain, are again useful for migraine in particular, but also for other forms of pain. And intensive short-term dynamic psychotherapy, which is a form of psychodynamic psychotherapy that focus on really uncovering all those emotions that have been suppressed or blocked, and people have a lot of defenses against them. This specific intervention has been researched for many other pain conditions and has been shown to have an effect. There was some study for migraine, but not a big one, and I don't think it's published. But ISTDP, which is one of the components of EAET, has been also shown to help with pain. So without further ado, I'd like to summarize by saying that, as we mentioned, pain is a danger signal. It exists to warn us about a real or potential danger, and anything that amplifies that can contribute to pain. Chronic pain can occur even in the absence of structural damage, such as nociplastic pain, which is important to know, where in nociplastic pain, a lot of the affective or emotional components are coming into play very much so, such as in migraine. We talked about migraine. That's a neurovascular disorder that imposes a lot of burden on the sufferers and their families. Stress disorders have been linked with migraine, such as depression, anxiety, and PTSD, and thereby contributing to disability. And we also know that childhood trauma, emotional conflicts, and unresolved emotion can increase the danger signal that is pain, and thereby leading to increased manifestation of migraine. So with interventions that we assume to be efficacious for chronic pain and migraine specifically, it will be those interventions that actually can address not just the coping mechanism of pain, but also those underlying emotional conflicts, the trauma, and other emotional stressors. And usually those, according to the research that we have done and there is in the literature, those actually show a lot of promise and efficacy in a lot of pain disorders, and we're actually looking forward to testing a lot of them in the pain field. So without further ado, that concludes my talk. I just want to say just one last thing. We have free resources for people who are interested. I'm working with the Danielle Byron Henry Migraine Foundation. We're giving courses that are free of charge. They're funded by the foundation. The basic course we're offering is called Resources for Migraine Management, which is a 5-week intervention that gives people a lot of resources in terms of pain desensitization exercises, working with negative self-talk, working with negative emotions, and so forth and so on. We're also giving online training in restorative yoga. We have a course in biofeedback, and we have other courses, and I'm going to put these slide, and I'm assuming you're going to get this slide with this presentation. So if people are interested, The next slide is going to give the email or the link to access those resources. And if people are interested, organizations that can help understand more about migraines, such as American Migraine Foundation, Danielle Byron Henry Migraine Foundation, Association of Migraine Disorder, and so forth and so on, they're very, they have a lot of information on their website, and so they can be very good if people want to learn more about migraine. Podcasts that exist, they're just online, and people are reporting their experiences with them. Blogs that you can access to learn about people's experiences and what helped them or not. And two movies that I highly recommend, one of them specifically about migraine called Out of My Head, and the other one is by those originators of EAT, which is called This Might Hurt. So Mark Lumley and Howard Schubiner, I highly recommend those movies that really emphasize how much the emotional aspect can affect chronic pain conditions. And of course, some books that related to some of the topics that I talked about, like Explained Pain by Lorimer Moseley, The Mind-Body Prescription, and Unlearn Your Pain, again, by Howard Schubiner. You're going to have that, I'm assuming, also with a presentation. So if anybody want to access the free courses or learn a little bit more about it, you can contact the Danielle Byron Henry Migraine Foundation, which I work with. And if anybody want to talk to me personally or ask me any questions, then my information is also on the screen. Cognize Mindful Healing, my website is pretty much indefinitely under construction, but you can have my email or my phone number. And if I haven't hopefully given you a migraine trauma or both by this point, that concludes my talk, and I'll be happy to answer questions. So thank you.
Wow, thank you so much. That was really interesting and informative. We have about 5 minutes, so if anyone has any questions, feel free to come on camera.
I have a question. Thinking about the contributors to migraine in terms of trauma and stressors, I have a question about effective medications like Elatriptan and Botox. If someone with migraines takes those and they effectively reduce or eliminate migraines, could there be something that's not being addressed that could then be perpetuated because a medication is eliminating a pain signal?
So if I understand you correctly, you're asking whether if people are taking medications and they have some reduction, but not complete reduction, if there's anything else. Would that be accurate? I think that in my experience, there's always going to be a continuum. There's always going to be some emotional, some physical, and the proportions are never going to be, it's hard to know the proportions. So it's like my approach is that I always first send people to a neurologist, medication, so forth and so on. Oops, someone started their screen share. Anyway, it is my opinion that a combined approach, meaning medication, medicine, and emotional affective component, is in order. Now, it's hard to say if medication do not work with emotional or behavioral intervention would work. However, in my experience, pretty much the people I work with are those that tried everything and nothing helps in terms of medicine. That's why they're going to the emotional aspect. Sometimes emotional aspect can have a huge difference, like a 78-year-old woman that is pretty much almost migraine free after 50 years of migraine. However, in some cases, it does not. So it is a little hard to say. It would be my recommendation to do both emotional and medical.
And if medicine is 100% effective, could that mean that the person who has the migraine is then ignoring pain signals that are being repressed by medication? I mean, could there be something there that should be paid attention to?
Absolutely, but
Okay.
we don't know. And usually if people are pain-free with medications, they would not go and try to look for anything else because the problem is resolved. Sometimes after several years, when the problem comes back and then medication don't help, then they might still look for something else. So,
thank you.
thank you.
All right. Let's see. I think Dixie, I think you're sharing your screen. I don't know how to stop that, but let's see. Was there one more question? Well, it is 8 o'clock, so let's see. I guess if anyone has further questions, I would encourage you to email Dr. Kaufmann directly. Does that sound good?
Dan.
Oh,
would you give his
oh,
email
Dan,
address
again? Yes. Let's
write
see.
it in the chat or something.
Do you want me to pull up the slide again just to put it? Okay.
Yeah.
I just went by too fast.
Okay. Let me just do that right now.
I had a question actually, really quick. Would you say did those resources and those movies in particular address how pain are those only about migraines, or are they also about other forms of pain, chronic pain?
So the first movie that I mentioned, which is Out of My Head, that's predominantly about migraine, but This Might Hurt is an amazingly excellent movie about various types of pain. They have some migraine in it, but it's not just on migraine. It's an excellent movie. The only thing is that you need to pay, I think, about $17 or $18. It's not free, but I highly recommend it. This is exactly the kind of movie that talks about how emotions and affect is related to pain conditions. So.
Very interesting. Thank you. And I guess one more question. The I don't know, the slide 42, I can't remember what it's called, that you're the program you're running.
Oh, this one. Okay.
The resource, for migraine management. Would you say would these restorative yoga, biofeedback, working with negative thoughts, and the forgiveness project, wouldn't those also help with pain other than migraines as well, chronic pain, or could they?
I would assume so. However, again, my specialty is for migraine, and this is through the Danielle Byron Henry Migraine Foundation. So they're mostly for people who are living with migraine disorders. I mean, I doubt we're gonna, we're gonna reject people just because they don't have a migraine, but it's mostly advertised among the migraine community. So.
Okay, got it.
Oh, I have another question.
Sure.
So these free resources, these trainings, are they for practitioners or are they for the people who suffer with the migraines?
No. They are for the people that are for those who are living with migraine disorders. We're teaching them specific skills to cope with their migraines. So in the resources for migraine management, we teach relaxation skills, pain desensitization skills. Some of them were mindfulness based. Working with negative self-talk, working with negative emotions, and how to create resources. So we designed this intervention specifically to help those who are struggling with migraine, not for therapists.
Not for therapists. Okay, thank you. That looks great.
Thank you.
Wonderful thing.
All right. So I will send Dan, if you don't mind sending me the slides, I would love to send them to everyone who joined, as well as the recording, and I'll send a CEU to those who put your email in the chat. If you were late for whatever reason, you can email me at ticnutah@gmail.com if you're in need of a CEU from this presentation. Otherwise, I'm going to, let's see, I'm going to stop the recording.